Hello and welcome to our podcast. My name is Dr. Sarah Abdelmaqsoud. I'm the head of the Specialized Radiology Services in the General Department of Radiology, Ministry of Health and Population. I'm honored to have as a guest today Professor Romarac Loffroy, right?
Perfect.
Professor of Interventional Radiology, Dijon University, France. Hello and welcome to our conference.
Good morning. Thank you very much for the invitation.
So this is the first interventional conference to our society. How do you find it so far?
Yeah, I mean it's very nice. I just came this morning and attending the first session about prostate artery embolization and so many different treatments. And so this is a new society, which is a very good news. Focused on intervention radiology and which is to me the future, because we do so many procedures in daily practice that it's a very good news to see this very exciting congress.
And the number of interventional radiologists is not that big. Dr. Mohammed always says that this is like the niche specialty with very few numbers. Do you expect that the number is going to expand over the years?
Yeah, hopefully. I mean, this is same everywhere, even in France, but worldwide. I mean, we are few doctors doing this, and the number of procedures is increasing a lot for many indications. So, and in some countries, especially in Egypt, where the population is quite big, especially in Cairo. I mean, it makes sense to have more and more physicians doing interventional radiology for treating patients. Yeah, I agree.
Do you have a certain specialty inside the interventional radiology, or you work everything?
Yeah, so in my department we do everything. So oncology, percutaneous, angioplasty, embolization. But let's say my main topic of interest, even if I'm still doing everything, is embolization in general. And especially embolization with liquids, liquid embolic agents. I'm a big fan of liquids in general. So we push the indications and for many good reasons, technical reasons and clinical reasons. So let's say that, the field of embolization, which is growing up worldwide, is one of my main topic of interest.
So I understand in Egypt how it works within the intervention radiology cases. In France, how does it work?
So in the department we do. So we have patients who have outpatients and inpatients, of course, but we do more and more interventions because this is minimally invasive. We do more and more outpatient procedures, especially for embolization, varicocele in women and men, prostate, even angioplasty. So I think because we do everything under local anesthesia, with some sedation, it's minimally invasive. We don't need anesthesiologists in most of our cases. So it's growing up this market and this field, doing cases in ambulatory patients, I would say.
So how are patients referred to your department? You mentioned that there are inpatients and outpatients, like clinics.
Yeah.
How are they referred? Do you have your own clinic of interventional radiology, or they're referred by surgeons or urologists?
Yeah, very good point. I think we have our own beds, and then so we are quite independent, I would say. And I mean, it's combined. It's a mix between patients referred to us by clinicians, surgeons, any kind of specialty, and some patients coming to us directly from GPs as well. And I think this is probably the key point that we have to highlight for young interventional radiologists. We have to make every effort to be as independent as possible and to have our own clinics, our own beds to treat our patients and to take care of our patients on our own, I would say.
So I'd say in Dijon University, the department has its own clinics.
Yeah.
That you see patients coming, walk-in patients, and they are seeking to be reviewed by a radiologist or diagnosed by a radiologist, who then refers to the step that goes after.
Exactly. exactly.
That means that some of these patients you can refer to a surgeon if you cannot handle them?
Sure, of course. Yeah. So we have multidisciplinary boards as well, and but if a patient is coming to me directly for something that I do, and if, for example, a BPH for prostatic artery embolization, if it's a good indication, then I will go for embolization, and then I will follow the patient. So we have to see patients in consultation, as you said, and to follow up the patients as well after embolization. Do the procedure, the intervention, and do the follow up and by ourselves. I mean, I think it's very important. Yeah.
But how does the patient know that this is a specialty of its own?
Yeah, it's a good question. I think patients, they know more and more now. We have, for example, we have a website mentioning all interventions that we can do. They are watching TV more and more. They are reading journals and everything to have access to minimally invasive techniques, because the surgery, I mean, we still need surgery, of course, and it's very important, but surgery can be very invasive for some treatments and for some medications. So patients are asking and looking at alternatives. So they know more and more. This is the case for fibroids in women. This is the case for BPH and prostatic artery embolization in men. So we need to be more visible, for sure, as you said, for patients.
So I would like to know, what is the latest technology or technique or something that you are doing that has had a dramatic effect on a certain symptom that the patient was suffering, or something that is new you're doing for the patient?
Yeah, so potentially, I mean, you can talk about that for 2 days. So,
yeah.
But if I have to choose, I would say I would choose two techniques. The first one is for sure prostatic artery embolization for BPH. To me, it has been one of the best techniques done over the last 10 years, and especially now we are pushing the use of glue for this purpose with to decrease the rate of recurrence of symptoms, and it's really a game changer in the life of patients, because you treat the symptoms, they are getting better with no complications compared to surgery. So which is a very nice step, I would say, in the treatment of this kind of patients. I've never had so many bottles of wine coming from patients since I've started to do PAE. So it means that during the follow-up, they are very happy about you and what you did for them. So PAE for sure is one of them. And the second one, I would say maybe a very fresh technique, which is the best technique, what we call bleomycin electrosclerotherapy for the treatment of venous malformations. We normally use a single sclerotherapy with different kind of sclerosing agents, but the results are unpredictable, I would say. And this new technique with electroporation combined with bleomycin is very promising in terms of clinical outcomes and the long term. So if I had to choose, yeah, I would to change really the life of patients, those two techniques, but so many other ones.
So I'd like another question, as you mentioned earlier, that usually you work in a multidisciplinary team.
Yeah.
Does that mean that there is no competition?
Good point. I mean, it can be competitive for sure, because interventional radiology is by definition something which is an alternative, a minimally invasive alternative to surgery and to surgical techniques. So of course it can be competitive, but my feeling on that is that the more you do different techniques and the more you get patients. So, and not only for radiologists, but for surgeons as well. If you are able to propose in a multidisciplinary team all kind of techniques, from surgery to minimally invasive techniques, in the end, it's a gain for everybody, because sometimes some patients are referred to me for interventional radiology and it's not a good indication, so I refer the patient to my surgeons. And the opposite, when it's not a good indication for surgery, they refer the patient to me. So in the end, and if you don't propose the new techniques, and especially in the field of interventional radiology, the patients will go elsewhere to get this technique, and you lose the patient. I lose the patient and the surgeon is losing the patient as well. So in the end, to improve and to increase the recruitment for everybody, surgeons, radiologists, proposing all techniques is always very welcome.
So again, I'd like you to highlight this part. How does it work? The decision for the treatment of the patient. It's a multidisciplinary team, and then the patient has a role in deciding the type of treatment.
Yeah, sure, of course. So depending on the referral, if they are referred to me or referred to the surgeon directly, but we try to give all information to the patient about the different techniques, and depending on the indication, the territory, the risks, the comorbidities of the patients, then of course he is involved in the decision.
But who gets the final decision? Is it the patient or the
It should be
doctors?
the patient. It should be the patient. In an ideal world, I would say it should be the patient, of course, because I mean, if he has all information, he has to choose one of the other one technique, and at least he has to be involved a lot in the decision.
But sometimes the patient is too scared to decide, or he's not enough educated to decide.
Sure.
Who takes the lead then?
I mean, we try to do our best. I think, I mean, it's not a big deal because in most of cases, depending again on the territory, the comorbidities, if the patient is under anticoagulant medication, very risky for surgery or for anesthesia, for example. And I mean, the choice will be very easy to do in the end according to all these features. So I would say the patient first, involved in the decision, and if impossible or complicated, then it makes sense to do what is to put in balance the risk and the efficiency of the intervention, whatever the intervention, radiological or surgical, what is the best for the patient.
So what was your talk about in this conference?
So my talk was about the use of glue for prostatic artery embolization.
Okay. What kind of glue?
So we use Glubron 2, which is a glue that we mainly use in Europe and in France, which is not a new glue. I don't like to say that because we use it for a long time, but let's say compared to Histocrete, which is a very old glue, and
this is like the modified version of the
glue.
old.
It's a modified version, which is easier to handle and to manage with less risks compared to old glues. And with a rationale in using it for PAE to get a very proximal and more durable occlusion of the main prostatic artery, and to avoid the risk of recurrence of symptoms by recognition compared to particles. So 2 randomized studies are going on in Europe about this topic, comparing particles to glue. And we try to promote the use of glue for this purpose for very good reasons, technical reasons and clinical outcomes, potentially giving better results.
Okay, and how was the audience taking it?
Yeah, I got a lot of questions. It was full. I was very surprised.
Really?
It was full. And a lot of questions and interesting questions because it's a hot topic. It's a hot topic because potentially many patients to treat worldwide, and there is a huge place and role for PAE between drug medication on one side and surgical techniques on the other side, with a functional risk which is very high and very important with surgical techniques, drug medication which are not always efficient, and then the role of PAE is growing and growing because very safe and very efficient in a minimally invasive way. So a very hot topic.
Great. So what is your take-home message to any young doctor, young radiologist who would like to specialize in interventional radiology or take the path that you are leading now?
Many take-home messages potentially, but the first one is that, we are probably doing one of the best specialty. I would say very, very interesting, a lot of improvement over the last 20 years in many techniques, angioplasty, embolization, percutaneous oncology. So we are really very, very involved in taking care of patients every day in our daily life. Surgeons need us all the time, not only for treating complications, but for treating patients from scratch as well. And I would say that for young physicians, they have to be involved in this specialty. And as I said before, they have to be clinicians. They have to become clinicians to see the patients in consultation, to do the techniques and the interventions, to follow up the patients as and to be a real and a true doctor, I would say, and a clinician to take care properly of all patients. This is the main take-home message. If you want to do intervention or radiology, it's not only a matter of technique, it's a matter of before the technique and after the technique for taking care of patients.
Thank you so much, Professor Romarac. It was very concise, informative, and fun talk. Thank you so much for your time.
Thank you very much. Thank you.
Thank you all for joining us in this podcast. Hoping to see you again in the next one.